So infertility is a very traditional dilemma, but though we cannot direct the wind, we can definitely adjust the sails.
A very good morning to all of you, respected chairpersons and dear friends. At the outset, I would like to thank the organizers for giving us, me and Mrinmayi, this opportunity of interacting with such a wonderful audience in this beautiful conference. As rightly mentioned by Mrinmayi, the times are changing and we need to adapt to the magical speed, the astonishing pace at which the infertility treatment is progressing.
Absolutely. So with respect to this, let's begin with our first case scenario. I'd like to ask Dr. Sadhana, who had also, I'm very blessed to call her my mother, about this particular couple, married since 6 months, trying for pregnancy since the last 5 months. Unfortunately, they were not successful. Comes to you for advice. So how would you guide them?
Let's have a look at what is the definition of infertility. Infertility is defined as failure to achieve pregnancy within 12 months of unprotected intercourse in a woman younger than 35 years or within 6 months in women older than 35 years. So in this particular couple, would like to know their age and detailed and thorough history, menstrual history, sexual history is very important because these newlywed couples, they have the problem of sexual dysfunction and they never open up and they directly present with infertility. So the medical history, surgical history and any particular family history is also important. If all these things are fine, a physical examination as well as a quick transvaginal scan is important to know any problem in reproductive system. If everything is unremarkable, this anxious couple just need to be assured, counseled and to be given folic acid supplement and they can try their own.
So before we begin with the causes of infertility, just a brief review for the process of fertilization for the benefit of the students present here. So first, every month an egg is produced in the ovary. It is picked up by the fimbria of the fallopian tubes. Ciliary action of the fallopian tubes pushes the gamete towards the uterus. At the same time, sperms which are deposited in the vagina, they swim upwards towards the ovum. And then ultimately fertilization takes place in the ampullary region of the fallopian tube. So friends, this is an example of nature at its best. Even a small error anywhere in this entire mechanism can lead to infertility. So the causes can be divided accordingly. Ovarian factor, so anything which does not release the egg causes anovulation. Most important example, polycystic ovarian syndrome. Tubal factor, any block in the tube, maybe due to pelvic inflammatory diseases, tuberculosis, pelvic adhesions due to previous surgery can cause infertility. Uterine factor, any submucosal fibroids, polyps, abnormalities in the uterine cavity with respect to congenital problems can lead to infertility, and cervical factor which does not let the sperms move upwards.
You have covered almost all the causes of infertility in this slide. Can anyone guess one factor is missing?
Often ignored factor.
Anyone? Yes, it's a male factor. Never ignore male as well as the male factor. At any point of time in life, make them work for us. So male factor is a cause of infertility in 40 to 50% of couples. To know the male factor, assess the male factor, go for semen analysis. It has to be done in an authorized lab and by trained personnel to know whether there are absence of sperm, that is azoospermia, to know the quality of sperm, that is oligo, astheno, teratozoospermia, and always request to assess both partners prior to any treatment.
So this is a very important point. When treating an infertile couple, make sure that you are assessing both the partners, do not treat only the female. Coming to the next most important factor, polycystic ovarian syndrome. It accounts for 80 to 90% of patients with anovulation. So here is a very common case scenario. 27-year-old woman comes with this ultrasound report. Bilateral ovaries show polycystic morphology, rest of the findings within normal limits. So this couple comes very panic-stricken that, doctor, do I have PCOS? Do I need to be worried? What should I do? So how would you guide this patient?
I am glad that you have taken this point for discussion. Any patient coming with the USG report of polycystic morphology does not necessarily mean she has polycystic ovarian syndrome. So, to diagnose polycystic ovarian syndrome, we have Rotterdam's criteria. Out of these 3 criteria, 2 criteria has to be there. The first is oligo and or anovulation. Second is biochemical and or clinical signs of hyperandrogenism. And third is polycystic ovaries. Polycystic ovaries on ultrasound is diagnosed by having 12 or more than 12 follicles of the size 2 to 9 mm in diameter in each ovary or ovarian volume more than 10 ml.
So it is very important to diagnose polycystic ovarian syndrome. Ask the history of the patient, menstrual history. Are the periods irregular? Is she getting periods every 2-3 months later? Check for clinical signs of hyperandrogenism, including acne, acanthosis nigricans, hirsutism, increased facial hair. Even these 2 criteria, if they are satisfied, in spite of a normal ultrasound, the patient may still be a case of polycystic ovarian syndrome. This is a ultrasound showing typical necklace of pearls appearance of polycystic ovaries.
For treatment of PCOS, there is only one Kalmi Karyakram, ek Kalmi Karyakram, lifestyle modification, and lifestyle modification. And it is in form of regular exercise, good nutrition with high protein content, and believe me, even 5% of weight loss can help to restore menstrual regularity, ovulation, and hormonal balance. The other important part of treatment for PCOS in infertility is ovulation induction, because the basic pathology lies in anovulation. They don't ovulate, so we have to induce them. That can be done with letrozole or clomiphene citrate or injectables in form of gonadotropins. But every time we have to monitor it by ultrasound to prevent OHSS and to know the timing of trigger. Letrozole is far superior than clomiphene as proved by meta-analysis.
The other adjuvant in the treatment of polycystic ovarian syndrome are insulin sensitizers. So insulin resistance and hyperinsulinemia is central to the pathophysiology of polycystic ovarian syndrome. It is responsible for that entire vicious cycle of hormonal imbalance. So insulin sensitizers like metformin, inositols can help these patients. Metformin has a proven benefit. There is evidence supporting the use of metformins. However, inositols still in the research phases.
Next important cause for ovarian factor infertility is low ovarian reserve. Let us see what is the concept of biological clock. Every woman has a fixed number of eggs at birth. At birth, it is around 1 to 2 million, and then it falls to 3 to 5 lakhs in puberty. Then it becomes stable till the age of 35. Then again it falls, and at menopause it comes to hardly less than 1,000. So and this biological clock is different for every woman. So that is the reason of different age of menopause in every woman and different fertility potential of every woman. So when you find out there is low ovarian reserve and the biological clock is already ticking, so one should not waste time and she should be offered some advanced infertility treatment. Otherwise, she will miss the next bus also.
So women with low ovarian reserve, whatever the reason, expedite her treatment. She doesn't have that much time.
So how can we know or suspect low ovarian reserve in a particular patient coming to you? Clinical history, like she may have irregular periods, scanty flow. Her age is important, as we have already seen. Then ultrasound day 2 scan can tell you low AFC count, and biochemical test, anti-mullerian hormone, low anti-mullerian hormone indicate low ovarian reserve. So causes of low ovarian reserve other than age are endometriosis, autoimmune causes, and the most important and very commonly faced problem by us is premature ovarian insufficiency. Previously we used to call it premature ovarian failure at a very young age nowadays. Next, coming to tubal factor infertility. The causes are recurrent PID, Second is, in India still we are facing tuberculosis and it is a major cause of infertility. Then previous surgery leading to adhesions as well as adhesions because of endometriosis. We can assess tubal factor by histosalpingography. This HSG showing bilateral tubal block with gross hydrosalpinx. It can also be diagnosed by sonohistosalpingography on ultrasound. But gold standard remains hysterolaparoscopy, where we can assess tubal factor by chromoperturbation. We can diagnose and treat endometriosis. Hysteroscopy is a complementary for laparoscopy, where we can do tubal cannulation, we can do septal resection, we can diagnose the anomalies of uterus, we can remove the polyps. So, very important, and the beauty of this procedure is histolaparoscopy is we can diagnose as well as treat the patient in the same setting.
So now coming to the male factor again, what are the treatment options available for male factor infertility? So let's begin with intrauterine insemination or IUI. So what is this process? Semen sample is collected, it is washed and processed, and the washed sperms are then injected with the help of a catheter inside the uterus. So this form of treatment is helpful for mild to moderate male factor infertility, mildly reduced sperm count or mildly reduced motility. Sexual dysfunction, again patients with erectile dysfunction, premature ejaculation, this form of treatment can help them. Cervical factor infertility, often this cannot be tested per se, but patients will present with unexplained infertility. Sperm retrieval techniques. So this is used in male factor which is very severe, severely reduced count or abnormal forms of sperms or absent sperms in the semen. So what is done here is that the sperms are directly retrieved from the testes, either by aspiration, procedure called as testicular aspiration or TESA, or by a small biopsy which is called as testicular extraction. These retrieved sperms are then injected directly inside the retrieved ovum from the female partner, a procedure which is called as intracytoplasmic sperm injection. It is done under a microscope in a lab with the help of a micro injection. So this helps in patients with severe oligozoospermia or even azoospermia. So now even males with azoospermia can father their own biological child, and that is the spectacular speed with which infertility treatment is advancing. So ladies and gentlemen, in vitro fertilization is the future, and the future is here. So a brief review as to what is IVF for the benefit again of the students present here. So at first, gonadotrophin injections are given to the female partner, controlled ovarian hyperstimulation is performed, and all the eggs which are grown are retrieved with the help of a small surgical procedure called as ovum pickup. Following this pickup, the ovum is cultured in the laboratory, fertilized with the sperms from the male partner, either by conventional IVF or, as I previously mentioned, ICSI or intracytoplasmic sperm injection. The formed embryos are then cultured in a petri dish, literally, in a laboratory, and these embryos are then transferred with the help of a catheter back inside the uterus.
Are there any recent advances in preserving the gametes or embryo?
Yes, so coming to embryo cryopreservation or embryo freezing. So what is revolutionized this practice is vitrification. Now vitrification is rapid cooling. So what is done is that these embryos are rapidly cooled so that it reduces ice crystal formation inside. It improves embryo as well as oocyte survival after thawing and increases the live birth rates. So what are the indications? Postponement of pregnancy. It can be offered to couples who want to postpone their pregnancy but do not want to fight the biological clock. For whatever, they have other priorities, they have other commitments. Second indication, fertility preservation. In patients who have been diagnosed with certain cancers or malignancies and they require some form of treatment in the form of radiotherapy, chemotherapy, which is potentially gonadotoxic and completely destroy the ovaries. Such patients also can be offered embryo cryopreservation. So this is a very recent news article, November 22nd, 2022 from the BBC. Twins born from embryos which were frozen 30 years ago. It sounds like it is straight out of a science fiction movie, but it is very true. It is believed to be a new record for the longest frozen embryos ever to result in a successful live birth, and this is the magic of vitrification. In today's time and age, where marriages are delayed, pregnancies are postponed, it is very important to think ahead and act now. That brings us to oocyte cryopreservation. Again, what is done here is that the oocytes or the ovum is retrieved from the female partner and they are frozen for use future so that they can conceive later. This can be indicated in patients again undergoing cancer treatment or women who want to postpone their pregnancy for whatever reasons again. Maybe they have just not found the right partner. So oocyte cryopreservation is no longer experimental. It is a very viable option and it is widely available. It is even, there has been a case report in which this has been successfully used in a woman with Turner's syndrome.
The older generation may think that instead of going for such high-tech technique like oocyte cryopreservation, it's way easier to go to a matrimony site and find a groom. But it's not true. Fertility preservation is going to be the future for next generation.
Yes, coming to sperm cryopreservation. So why should girls have all the fun? Sperm cryopreservation again is a very viable option for young boys and men with malignancies like testicular tumors, non-testicular malignancies before any gonadotoxic treatment. Storing sperms when the partner is away also prevents delays in IVF cycles. And another very important indication for sperm cryopreservation is when the partner is not able to give a semen sample at the crucial time of oocyte pickup. The last advancement which I would like to cover is pre-implantation genetic testing. What is done here is that the embryo, prior to its transfer into the uterus, is tested for any genetic or chromosomal abnormalities by a small biopsy which is taken. This helps in transferring only euploid embryos, that is healthy embryos. It is indicated in patients who have or who are carriers of genetic disorders, those with recurrent pregnancy losses, recurrent implantation failures, and in older patients in whom genetic abnormalities are quite common. So friends, we have come a very long way from India's first IVF baby, Durga, who was born in 1978. She was the brainchild of the brilliant doctor and scientist, Dr. Subhash Mukherjee. The field of assisted reproductive technology owes him tremendously. So we would like to wrap up with a few take-home messages.
Infertility assessment is incomplete without assessing both partners. A good history and examination is absolutely necessary. PCOS is diagnosed by Rotterdam's criteria and lifestyle modification is the first line treatment. Patients should be offered IVF in a timely manner when indicated. Fertility preservation by gamete or embryo cryopreservation should be offered to all the patients who would benefit from the same.
So I would just like to end by saying that the wheel of research and development continues and we must keep abreast with its speed in order to maintain the sacred chain of life. Thank you so much everyone for your valuable time.
Thank you. Thank you very much.
Fine support.
Thank you so much.
This is the first lecture which is on time.